pave the way for the policy that we are building. Obviously, a policy aficionados. So before that, I just want to ask a very naive question. What do we do to ratify a unique identity? How we can say that we are the one as far as contemporary India is concerned? Well, undoubtedly and certainly we show Aadhaar card. Then you must be wondering about the mind who unleashed this tremendous intervention. So I'm immensely gratified to introduce a speaker for today's session, Dr. R.S. Sharma sir, who brought this intervention. Sir is the CEO of National Health Authority, and sir did his MSc in mathematics from IIT Kanpur, which is again a conceit in itself for us. Later, he joined Indian Administrative Services in 1978. So on the behalf of Public Policy Opinion Cell, I welcome you, sir. It is a fortune of us to have you here. Also, we have with us Professor Pradeep Swarnakar. I welcome you too, sir. Associate Professor, Department of HSS and Faculty Counselor of Public Policy and Opinion Cell, whose constant guidance and motivation has made the summit possible. Pradeep sir is an environmental socialist specialized in climate change policy, social network analysis, and sustainability transition. So I would like to invite you, sir, to address this August gathering. Professor Pradeep Swarnakar, sir, over to you.
Okay, thank you, Shubhankari and Nikhil and Aditya. And I'll not take much time. I'll just take 2 minutes because everyone is looking forward to listen to Dr. R.S. Sharma. It's an honor and privilege for us. So I'm in the Humanities and Social Science Department and work generally in climate and energy policy. But also our department definitely interested in health-related policy. Many PhD students from our department, particularly the discipline of sociology and psychology, worked on various health issues. So I strongly believe that the students, when I am teaching undergraduate courses, are very much interested in HSS courses because they are somehow linked to the daily life activities. And some of the students later joined the Indian Administrative Service, and many of them actually wrote to many of the professors that, okay, this kind of courses were helpful to understand the society better. And that's why a few years back in 2018, the undergraduate students of IIT Kanpur established this Public Policy and Opinion Cell, also in a different name. And then we do a lot of workshop, conference, Indian Government Summit, India Conclave, so various events. And I'm really thankful to the entire team of the PPOC for organizing this. And thank you, everyone, and welcome, sir, to our this session. Over to Dr. Sharma.
So before that, thank you, sir, for addressing the session. So before sir would proceed, so now I would like to talk about some of the astonishing benchmarks of a guest speaker, Dr. R.S. Sharma, sir. So as the Director General and Mission Director of the Unique Identification Authority of India, sir helped in formulating and launching Aadhaar, India's first and the world's largest biometric identity system. He also heads the technology backbone for vaccination process COWIN. Sir too has served as a NHA CEO as the chairperson of the Empowered Group on Vaccine Administration for COVID-19. He's also responsible for Ayushman Bharat Pradhan Mantri Arogya Yojana, ABPMJ, world's largest fully government-funded health insurance scheme, and Ayushman Bharat Digital Mission, National Digital Health Mission that aims to develop the backbone necessary to support the integrated digital health infrastructure, which was launched earlier in September by our Honorable Prime Minister Narendra Modi. So we all know that the very topic on which sir would address us is the National Digital Health Mission, which aims to create an integrated healthcare system, linking practitioners with the patients digitally by giving them access to real-time health records. Henceforth, I would like to invite a guest speaker to take over and enlighten us on this very topic. Dr. Arish.
Well, thank you, Shubhankari, and thank you, Dr. Pradeep Swarnakar, for starting this session. It's always a pleasure and a privilege for me to come back to my alma mater and talk to all of you. I do not lose any opportunity to visit IIT Kanpur. So whenever something comes up, whether it is selection of the distinguished alumni or something else, I always make it a point and utilize that opportunity. And Dr. Abhay Karandikar has become a great friend, and he was also a part-time director in the Telecom Regulatory Authority of India, where I was the chairperson. So I think I have, and of course, my association with IIT, living in Hall 4 and having all those memories, that's a very invaluable sort of treasure which I always cherish and treasure. So, and also I would like to thank the Public Policy and Opinion Cell at IIT Kanpur for inviting me to India Governance Summit. I always feel that while we study technology, it's the public policy and the policy which should basically drive the technology. And therefore, I think it's in fitness of things that now a number of IITs are going in for schools of public policy or some kind of departments or some kind of faculties or a group which deals with the public policy, and I think that's also a very good step. So today, what I'd like to share with you this afternoon, I don't know how much time do I have, Subankari, how much time do I have?
Aditya, can you tell me how much time sir has?
So you can present as long as you can. Most tentatively, we can have the entire session of around 1 hour to 1.5 hours.
Okay, now in that case, if you want me to do that, I'd like to share some content, because then it will help me in focusing the discussion, and probably it will also help me to articulate my thoughts in a much more coherent manner. So I'm trying to
I've
see,
switched on the screen share.
Yeah, I don't know screen share if I do, and it says Zoom start broadcast. So, okay, now, okay, let me
Yes,
see.
sir, it is coming up.
What do you see? Let me see. Actually, I'm out of office and therefore in a place which is the connectivity can be a bit of a challenge. So, let's see.
Yes, sir, your screen is visible now.
Okay, and I have put up something on my screen. Why is it not coming? Actually, I will. No, it's a problem. It says stop share, and then it says screen. There is some problem. Okay, now let me then in that case.
Sir, if you're not able to share, then what you can do is send that to us, and
Yeah,
then we.
that will be better. So, can someone give me a mail ID, and then I'll mail it, and then you can share it from there. Can you hear me, please?
Yes, sir. Yes, sir.
Any mail ID, Gmail ID will do.
Yeah.
So ppOC.itk.
BP.
Yes, sir.
Yes.
ppOC.
B for Bombay, P for Patna.
So both P for Patna only. ppOC.itk
oc.iitk
@gmail.com.
So, okay, I got it. bpoc.iitk@gmail.com. So I am sending you these. There are two files. One is a PDF file, another is a PowerPoint. Whichever one you feel comfortable, you please share. Yes, friends, did you get it?
No, sir, it hasn't yet come.
Oh, it says mail is failed, address not found. Oh, let's give it. What is the B for Bombay?
So P for Patna only. PPOC dot. So I'll just type it in the chat once.
Okay.
Yes, sir. It's already in the chat. ppOC.itk@gmail.com.
Oh, I can't see the chart also. Acha, okay. PPOC. Oh, you have been saying BBOC, so that's a PPOC. IITK. PPOC, right? Yeah. Now it is sent. The earlier one returned back. Did you get it, friends?
Yes,
Yes,
sir.
sir.
I'll just.
Okay, now you can share whichever one you want, either PowerPoint or PDF.
Yes, just a minute.
Yeah, this is the one, and you can make it into a. So this afternoon, friends, I am going to talk about the digital health system. The Honorable Prime Minister on 27th of last month launched this program called Ayushman Bharat Digital Mission, and I would talk as to why this program is so important. And imagine we have all been passing through a very, very difficult time because of Corona. That health has always been in focus, but this has become much more focused now because it has been such a disaster and such a bad period for our country and also for our entire world, in fact. So can you go to the next one? So we are actually, is the second one? Yeah. So one, let me begin by saying that India has done something very, very unique in the digital space during the last about a decade or so. So we started building Aadhaar in 2009. And that problem was an extremely important problem because we wanted to remove duplicates and hosts from the government beneficiary databases. So the challenge was to create unique IDs for every person in this country. And unique assuring, creating ID is not a difficult problem, but creating unique ID is certainly a very, very difficult problem, especially for a country of 1.3 billion people. So essentially, what we started doing was we built Aadhaar using the biometric attributes of people, which nature has made unique. So fingerprints and iris, combination of two multimodal, two different biometrics ensured an accuracy level of 99% plus. So we were able to create unique identities, and we created these as digital identity, online identity, which means they can fit into any transaction. So they can become a part of any transaction. And these IDs were basically bereft of any eligibility, which means they were just identities. So one could unbundle the eligibility and identity and then actually combine them in any transaction. So for example, if you are eligible for getting ration, then your entitlement of ration can be on the cloud and your identity can be on the cloud. And at the time of delivery, both of them can be combined, which means that you first prove your identity and thereafter your eligibility also gets combined with that. So this became a digitally pluggable identity for any transaction. And this became an extremely important facilitator for public service delivery. So we have 1.3 billion unique Aadhaar digital identities. Then, of course, on top of Aadhaar, we have done thus far, you'll be surprised to know, we have done 57.5 billion authentications thus far, which means on an average, every Indian has authenticated 50 times in the last 10 years or so, or last about, first Aadhaar was issued in September of 2010. Then, of course, we have done electronic KYC transaction, which means that digitally you can actually provide a digitally signed artifact called electronic KYC, and you can do any transaction. So people are buying SIMs using electronic KYC, and there are multiple things which are being done. Then, of course, we also came up with an idea of money transfer, and actually we generated and created a completely new artifact called Unified Payment Interface, and that artifact was launched by the Honorable Prime Minister of India in December of 2016. So in the last 4.5 years or so, we have done so much that now the UPI transactions actually surpass all the debit cards and credit cards by an order of magnitude, which means we are having, for example, last month we had 3.424 billion transactions, which means about 10 crore transactions every day. That more than that, and I am sure every one of you is familiar with Google Pay, Phone Pay, Paytm, Beam, everything. So this is how those transactions have gone exponentially. Then, of course, we created what is called a digital locker, which means that every person will be able to have a private space on the public cloud, which is based where he can keep his or her documents. So the digital locker, and so thus far we have done 4.5 billion documents. All your degrees are also on the digital locker. So they are digitally signed and digital form, and they can be shared, and you can sign your digital signature. So we created what is called e-sign, a digital signature on demand. So we have all these public digital goods which we created over the last decade. Also, simultaneously, we had connectivity. We were working on connectivity. So now we have almost every village in this country has got connectivity, and that is also 4G connectivity. So it may not be a very robust, because it's all wireless. So therefore, there are certain sort of vagaries of weather which wireless is subjected to. But nevertheless, they were very robust connectivity systems. And we had 780 million internet users. We had 600 million smartphones in this country. And data rates are the cheapest in the world, and therefore, India is the only country in the world where people are watching, films on the mobile phone in the villages. So this is, and we are actually consuming 12 GB per data per month, 12 GB of data per consumer per month, which is the highest in the world. And we are having 8 billion GBs. You have those exabytes, 8 exabytes, which is the gigabyte, petabyte, and exabyte. So this is the digital access. So we have done a lot of work in the digital access area. We have also created a lot of public digital goods and new digital health solutions. The COWIN platform was launched on 16th of January this year, when the Prime Minister launched the vaccination program in this country. And today we have about 900 million people who have been given vaccination on the platform. And each person's certificate, each person's registration, each person's vaccination records are available online. I mean, there is no platform in the world which has scaled so fast, so much. In about 9 months, we have done about 900 billion. So this is what is happening. We are having Arogya Setu downloads 20 billion, 2 crore downloads, have 20 crore download happen. In fact, it is 200 billion, not 20 billion. And 5 million consultations are happening on teleconsultation, application called eSanjeevani. So all these things have already happened. And you might ask a question, so what? Every country has been doing this. No, every country has not been doing this. Every country, no country in the world has such a power system can have this. If you are doing a teleconsultation with a doctor, then you need to pay the doctor in a digital manner. You need to share your certificates or prescriptions in a digital manner, your diagnostic report. The doctor has to prescribe the prescription in a digital manner. So all digital transactions will require such kind of digital, protocols or digital artifacts to happen. And all these things are available in our country. So therefore, we have, and all these, stuff is resilient, scalable, affordable, and ubiquitous. I mean, imagine affordable. If the UPI transactions are free virtually. In fact, some of the players give you rewards also for conducting transactions on their platform. So that's the way we have built. We have built frugal, artifact. We have also built interoperable. That means they are not silos. They are all talk to each other. So, and scalable, of course, numbers are huge and humongous. So can you go to the next slide, please? Hello? Yeah, so one is, I wanted to say this, that the COVID-19 has shown two things. One is that our health needs, we respond with informal, fragmented, and local services. So you must have seen, when the second wave came and when there was a crisis of the cylinders, oxygen cylinders, or there was a crisis of remdesivir, then, everybody was running helter-skelter. There was no systematic, there was no, focused or systematic platforms on which you can get information. So you were creating WhatsApp groups and calling someone and manual searches. This is really what happened. So that exposed the vulnerabilities in our system. So what has happened is that we have built a lot of digital artifacts, but somehow we have not put together into a coherent, platform which can systematize this entire, effort. And of course, we need, teleconsultations, and we need to reach a remote area with medical guidance, etc. That is very clear, because people in the COVID times, they were not able to visit the hospitals because hospitals would provide them infections. And they suppose they fell ill, they did not know what to do, and they were consulting and other things. So I think one of the impact which COVID has created is people have started using the digital means quite frequently. For example, I am talking to you, all of you, in a digital manner. Now, in normal times, probably I would have traveled down to IIT Kanpur and sat along in L7 or whatever that hall now you have got, big hall, and then I would have talked to you guys. But now this is happening, and I'm quite comfortable talking to you, and you are also quite comfortable listening to me or listening to such remote lectures. So this has now become a trend, and I think it also has some positives, I must say. So that will hopefully continue even after this disease or this pandemic has passed away. Next, please. So basically, we need to create a resilient and future-proof healthcare system. We need to create a unified network. We need to match demand with supply. And this should happen across all sectors, private and public. And this will enable a person, a rural area, he basically is able to teleconsult. He can digitally discover a local lab that can do the testing. And then, of course, he can buy medicines online. And then finally do, other consultations with the doctors after his diagnostic lab reports have come. So this way, I think this whole health transaction can become quite digital. At least till he goes to the hospital, because obviously hospitalization will require a doctor sort of, if there is an operation which is to be done, then obviously that cannot be done digitally unless you are thinking of 5G, which can do remote surgeries also, but which is a little far away from our country's perspective. But this is how it will happen. Next, please. So is the slide? This is the next slide, right? Now, this is just a slide to show that we have the capacity to build digital infrastructure, a scalable infrastructure, and COWIN Dashboard. If you go dashboard.cowin.gov.in, which we designed in the month of January, that shows, that we are able to show the entire country. And, we took about 25 million, sort of vaccinations were done in a day on 17th of September. And before that also, we had done about 10 million in a day. And that actually translates to a huge number of hits on our system. And our system has scaled and our system has become resilient and robust. So that is the kind of infrastructure which we are capable of building. And it provides a single source of truth for all things. So now, nobody talks about that, because this is the single source of truth. So किस state ने कितना किया, किस जिले में कितना हुआ, किस facility में कितना हुआ, all those things are available on this platform. Next, please. So this is the most important, slide of my presentation, and I just want to tell you the architecture of building the digital mission which the Prime Minister launched. So one is that we have, as I said in the beginning, we have created a number of digital artifacts which actually can provide service not only to health part but to any domain. So whether it is agriculture or e-commerce or any other domain, these products are all horizontal products. So for example, we have Aadhaar, we have UPI. We now have come up, the Prime Minister launched another product called e-Rupee, which means it can be a direct benefit transfer with a purpose. So I can say that I am transferring 100 rupees to you to basically that you buy a cycle, or 2,000 rupees to 100 rupees. Of course, cycle could be bought in our times, but not anymore. But probably now it costs 5,000 rupees. So I will transfer you 5,000 rupees, but you can't get the money redeemed unless you buy a cycle. So that's a very interesting combination where we have made person specific and a purpose specific voucher. E-sign is a facility where you don't need a dongle to digitally sign. You can just sign on demand. So we have now made it a OPEX kind of facility rather than a CapEx one, because your identity is on the cloud and public-private key pair can be just delivered from the cloud and you can sign a document. And we had created consent artifact way back in 2015. We actually notified what is called a consent artifact. And that is so important because in digital world, consent has become very, very important. I can't share your data unless I have your consent. And how do you give consent? You can't give an affidavit or written, paper consent. There is a digital artifact which should be shared with me as a token to say, and that you can present to anybody with a request and with an authorization to share the data. So that's how this consent artifact works. So this is and of course JAM, Janadan Aadhaar and Mobile, which enables transactions to take place, the DBT to take place. So these are the public goods which we have created. The second one is health data exchange. So this could be replaced for agriculture, by commerce, by anything. So this is essentially an abstract view of any kind of domain platform which you are building. So this way you can build these platforms. So we can build on this top of these digital infra. We are going to build digital registries of health identity, healthcare professionals, health facilities, drug registries. These registries will be the reference files, as they say. These reference files will work to be accessed by everybody. Then, of course, we will build the health information exchange, which is basically the document standards, health data analytics, health information exchange, and consent manager. This is what the other layer. Then, of course, claim standards. So basically, many of the digital health issues will be insurance based, and we will probably need to create a digital claim platform, a standardized platform for the patient. So that's what we will define e-claim standards, and then of course policy markup language, bill markup language, all these things will be decided. And on top of this data exchange, we will create what is called unified health interface, which is similar, we are naming it like UPI, unified payment interface. Similarly, this is health interface. This is like a gateway, which will enable. So let me, before I describe the gateway, let me describe the top layer. The top layer is basically the user applications. So applications facing the user. So you can think of Arogya Setu, eSanjeevani, other apps. You can think of hospital management information system, lab management information system. So these are applications facing the user. So for example, if you have an application which actually Suppose you are searching for a doctor, whom you want to teleconsult with. So therefore, you will basically interact with this platform, and the first layer, which essentially will basically enable you to book, search, and schedule appointments. So essentially, this layer, which is the unified health interface layer, provides that kind of resolution of your requests, and it takes help of the artifacts below that layer to comply with the request of the top layer. So basically, you have telemedicine APIs. We can discover a doctor. We can book appointment. We can do teleconsultation. Labs and drugs API, which will discover labs, discover pharmacy, avail services, and of course, bed availability, hospital availability, blood availability, emergency services. All these things will come in the data unified health interface layer, which will actually enable, and they will search the layers below to provide the services. And this is actually an interoperable architecture, which means that it does not make a difference whether you use one NG or you use Practo application, but you will be able to interact with the entire set of facilities available. Next, please. So essentially, what we are trying to create is a unified but decentralized network. It's not that all the data is residing on this platform. This platform is only a schematic diagram, which means that data will reside wherever it resides normally. So let me give you an example. Suppose I want to have access to my health records. I had visited Apollo, I have visited Nalpath lab, got the test done, and I have visited some other facility. So what is happening is that we will define the unique health ID, the health ID which is provided by the system, will essentially be using that ID is merely a reference number. That ID is nothing, it is bereft of any intelligence. It essentially is a reference number with which you will be able to link all your records. So once you link the records, then the records will continue to remain wherever they belong to. That is Apollo Hospital, Max Hospital, or Nalpath lab. But whenever you go to a doctor, you will be able to visualize all these records, access these records, and show it to a doctor. And the NHA, which is the consent manager, will work on your behalf to fetch these records and make it available on your mobile so as to be shown to a doctor. So that's the architecture. So essentially, it's a decentralized network, but it's a unified network. And basically, how does it work? How does Nalpath lab give you the access irrespective of which application you are using? Which public personal health record application, PHR application as it called using? That happens because there is a standard protocol of data interchange, of interchanging the documents. So this is how we are construing and constructing, which will not give the it will not become Amazon of the country. It's not an Amazonification of the whole health services. No, not at all. This is essentially a very democratic platform, which is open, inclusive, based on a standard, based on open APIs, and of course, based on the open source stuff. So you can discover hospitals and primary care, labs, pharmacies, medical across pharmacies, and you can book an appointment like you can do now in COWIN, for example, check availability of medicines, labs, or the blood or other kinds of things, and number of critical care beds available. That also you can do. So essentially, this platform will enable you to participate in this will also provide access to remote areas, because fortunately we have connectivity in remote areas. We do not have doctors in remote areas, and this will enable remote areas people to be able to connect with a doctor who can talk in his or her language, and who can provide the appropriate advice. Next, please. And by the way, can you come to the previous one? This is not going to be only an allopathy kind of network. This is previous one, please. This is not going to be an allopathy. This will be Siddha, Ayurveda, fitness, ENT, Asha workers, yoga. Everybody is going to get into this network. Only thing is that we will do a due diligence to ensure that only the quacks don't enter this platform. So therefore, the doctors will be onboarded on this platform only after approval from their medical councils, etc. So that's the we want to maintain the purity and at least the authenticity of the people on the platform, so that people have trust in actually consulting the doctor on this platform. Next. So essentially the difference between the other kind of platform which are in existence and the network which we are making is that, currently the platforms have to vertically integrate themselves. They have to have their doctors and hospitals. They have to have their proprietary protocol, and they will have to have their own patients. So somebody is working on 1 mg, then 1 mg doctor, 1 mg lab, 1 mg pharmacy. Everybody will belongs to 1 mg, but that will no more be there. So basically, we will bring those silo protocols, silo platforms will not be there, and they will continue to exist. We are not saying that we will finish them off, but essentially this will provide a much more open and interoperable platform. Next, please. So essentially, we hope it will benefit every stakeholder: the citizens, the doctors, the pharmacies, the diagnostic labs, and health tech startups. In fact, the last one is the most important one, because many of you are going to open your startups, and essentially what is happening is that currently when you do a startup, then you have to figure out everything. You have to figure out who will be my client, who will be my doctor, who will be my lab. I'm talking of health space. Now you will just be able to plug and play, because all the reference databases, the doctor's registry, the drug registry, the lab registry, everybody is available to you. So essentially your cost or time to market becomes absolutely less compared to what it is today. So that will, kind of invigorate a whole new set of startup systems in this country in the health space. So that's basically, and you can see why it will benefit. So, for example, citizens will have better access to healthcare, will have choice to providers, they will have competing prices, because that's very important. Somebody says I'm giving this drug and this much, and somebody says I'm giving less. Why not? So customer is very important. So that will happen. Then they will have control over their own data. This data is not the one which is going to be stolen by somebody. They will be there. We have an architecture in place called Data Empowerment and Protection Architecture. So this essentially enables that a person can use his or her data for his or her own benefit. So this is all is going to happen. It will benefit doctors, it will benefit everybody. So it will become the inclusion, accessibility, affordability, and diverse innovations. Everything is actually one of these are some of the overarching principles of this protocol. Next, please. So we this is a study done by BCG and FICCI that it will have about $200 billion impact of NDHM, which is basically the Ayushman Bharat Digital Mission, and they are saying it will lead to market expansion and it will lead to cost efficiencies, and they have actually broken down as to how much will be the impact of each of these verticals. Next. So I think, friends, this is all I had to say. Now I'll throw open to the audience in case you have planned any question answer session. But the essential idea was to tell you three things. One, India has built over a past decade a number of digital infrastructures, public infrastructures, which actually can become enablers of doing many things and building many products on top of them. And two, we are through the Ayushman Bharat Digital Mission trying to leverage that infrastructure to ensure that we can provide affordable, accessible, and quality healthcare to our people, and we leverage technology to the best extent possible. And thirdly, we can probably sort of export or replicate this kind of philosophy and theory and practice in other sectors as well. Thank you very much.
Thank you so much, sir, for sharing such a conspicuous information about the digital health mission and why are so these things important and exigencies for the nation like India, since we know that technology is the bandwagon, and our government, that is or specifically our Honorable Prime Minister, is also stressing a lot upon the intervention of the technology in each and every sector. So my question that out of curiosity that arises is that this digital transaction was started more of because of COVID-19, or was it because of the demonetization that actually happened in 2016? So how can you make people choose digital healthcare systems when there is a lot of apprehension among the people, and they are not very much educated about the health literacy? So how we can persuade them to move forward for that case?
I think it's an extremely valid question, Subhanti, because you are right that unless people have trust, there are two things which are required, as I always call 3C. One is convenience, another is confidence, another is cost. So unless these 3Cs are there, people do not transact or people do not enter a system. Now, fortunately, digital systems have become very convenient because applications have become very user-friendly. Now, operating your mobile is not such a great challenge which used to be earlier. Writing a program on a Unix system or things like that. So you have to learn all the commands. That's no more there. Number one. Number two, people have developed trust in the system slowly and slowly. People are transacting. For example, the fact that a Rediwala is a sabji seller is also accepting payments on Paytm or other digital mechanisms. The proof enough of the fact that if you give technology to our people and if the technology is frugal, is reliable and robust, people do adopt technology. So that's one part. And of course, the confidence is there and the cost. So if the cost gets reduced, certainly one would like to. Now, suppose a person sitting in remote rural area of Jharkhand, he has to travel down to Delhi and just to show to the doctor, and doctor says that koi problem nahi hua hai, this could have been done when he's sitting there and he uses a teleconsultation with the doctor in AIIMS, and doctor in AIIMS, after examining his diagnostic and after seeing him and after talking to him, gives the same opinion. Now, why would somebody like to go and travel down to Delhi because it's so inconvenient, so costly, and so time consuming? So essentially, slowly and slowly, you are right that one has to develop confidence in the system. People do develop confidence in the system, provided the system is fair enough. Today, why people have developed confidence in COWIN? कि भाई ठीक है, मेरा सर्टिफिकेट निकलेगा, मैं जाऊंगा, मैं अपॉइंटमेंट ले लूंगा. So basically, that's because if we make systems robust, if we make systems reliable, if we make technology friendly to the people, people do adopt. After all, 1.2 billion mobile phones, people are talking here. लोग तो खूब बढ़िया से बात करते हैं, लोग वीडियो कॉल कर रहे हैं काम के इलाकों में बैठकर. So people are using technology, and I think adoption of technology is not an issue anymore. What is the issue is, obviously you must give them technology which is friendly, which is which people can use and which people see value in. आज लोग 5,000 रुपए का मोबाइल फोन खरीद रहे हैं, despite the fact that they are not able to sort of invest 5,000 rupees in any luxury item because their income is not much. Even laborers or small people, they are doing it because they realize that it is 5,000 rupees worth of investment. It is not a luxury anymore. It's not only something which you can talk with, but it is something which you can pay money, you can do many other transactions. That's how.
Yeah, thank you, sir. But if we parallelly see the situation, so COVID-19 has also pulled down a lot of people below poverty line. So a problem arose there too. And another problem is that with the people that they are confining their own details on a platform. So how they can be so much assured about all the details would be protected, and how far the laws are going to be strict to, to mitigate all the problems that people usually think that they might face during such things. Avoid any kind of personal health.
Yeah, I understand, but technology cannot solve all the problems. Let's understand that. Technology is only an enabler and can solve some problems. Of course, it can solve some of India's hardest problem, and that technology is the only way one can sort of solve these problems. So that's one part. And secondly, obviously, a lot of reforms will have to be done in terms of the legal framework. A lot of reforms will have to be done in terms of regulatory framework. So those are continuing processes and will continue to happen. But what I'm saying is that overall, I see a great future for startups, for technology, for delivery of services in an affordable manner in a country like India. India is not, it's not a small country. People have countries out there which is 1.3 billion people. 13 lakh की population है Estonia. Now, हमारी population उनसे 1000 गुनी ज़्यादा है. 1.3 billion and 1.3 million. This is the difference between Estonia and India. So I think, yeah, the big country and multi-language, diverse, cultural, ethical, what is called, not ethical, cultural and ethnicities, they're there. So this is a very diverse country. And obviously, it has complex problems. Every problem cannot be solved by technology, but I think one should continue to make dent into these problems whenever possible, and technology is one such method.
Okay, so from your consent, can we take the questions from the audiences, because some of the participants are raising their hands to just ask the questions.
Sure, I will be there for about 8-9 minutes.
Yes, so
I have another.
Whoever is interested can raise the hand and we will unmute.
Yes, sir, Professor Sir.
Hello. Thank you, sir, for very informative talk. And there is no doubt that India has done like an enormous thing in terms of digital health. And it's thanks to the government machinery and all the people who are engaged in this. We are getting our COVID certificate and everything. So I have a small question for my students, because IIT Kanpur, under the leadership of Professor Karandikar, as emphasizing on innovation and incubation, particularly the startup by the students. So if some of the students are really interested in this healthcare informatics and all these things, so in which area they should go or something like that? If you have some suggestion for our students, some inputs, very brief, but that will be really helpful, sir.
I think, Professor, this is a wonderful question. I mean, obviously, let me also, caveat this answer to this question by saying that in my entire career of more than 4 decades, I have never worked in the health sector. This is the first time I have been put in charge of the National Health Authority, and that too from February of this year. So it's just about 7-8 months that I have been there. But from the little experience, I can say that there are, for example, areas related to diagnostics. So I find that there are many, tools which have been developed using technology. The other day I was hearing Sundar Pichai, and he was saying that retinal scan or the eye scan, not retinal scan, some other eye scan can actually figure out, give you an idea about the marker about the health conditions relating to diabetes, relating to other heart conditions, etc. So I think there's a lot of research which is happening in terms of finding out scalable diagnostic systems. So, for example, if I can find out the curvature of my eyes and what is the mere lens ka kitna number hai, and if I can do that quickly using, let's say, some other software or smartphone, then how good it will become. Then you can have a massive chashma bana ke aap bhejne ka program chalu kar dijiye ki bhai inko sasta chashma, because now they don't have to spend money in doing the डॉक्टर के पास जाएं और वहां पे वो अपना तरह के लेंस लगा के देखें. So that's also, I mean, what I'm saying is that diagnostic is one area which I find extremely promising, because if you can reduce the cost, if you can make it instantaneous, if you can reduce time, that will be a wonderful area. Of course, there are many other areas where one can do startups. Of course, people have learned to do startups in the area of aggregation, demand aggregation. You have Zomatos of the world, or you have Swiggies of the world, and you have 1MGs and Preptos of the world. So those things have happened, and those things will continue to happen. But I think more value addition part, where you can provide help to people to diagnose their problems at an early stage or in a very cost-effective manner, or at least early indications of some problem which can be done quickly, easily. That will be a great contribution from a startup.
Thank you, sir. Thank you. And I hope that students are listening, and they will also contact you or your department if they are, because there's some idea or something. Thank you. Over to Shubhankar.
Yeah, I would just insist the participants from the audience that they can ask the questions they want to, based on whatever sir has just delivered, and out of the curiosity, if they have any question pertaining to that National Health Digital Program. Okay, so somebody has raised the hand. Akshay.
Hello, sir. It was a nice session. I'm here. I don't had that much of experience on this, but still, when I was, I don't think this question is that much relevant, but still, I'm curious to ask this question. So, when there was Ayushman Bharat was started, there was some kind of things which we used to say that there should be some minimum uh, qualifications to that family. The family should be under family should not possess that much of assets. The family should be like this. We have some certain criteria. So in my case, I can see some of the families, they own asset, like there's some 100 or at least 50, 70 years of assets, which is not into anything, but they are just having, and they don't get any income out of it, and the family is in poverty line. Those people can't, as they are possessing some assets which is not really useful, but in the name of assets, that families are not getting the rights, like they are not into the Ayushman Bharat scheme. So what can we do for it? Like, in what way we can just make some changes?
Yeah, I think, I get the question. What is happening is that the Ayushman Bharat PM Jan Arogya Yojana basically focuses on those people who qualify under the 2011 socio-economic caste census, which was done. So there are certain deprivation criteria, and in urban areas there are some occupational criteria due to which they are qualified. I agree that since then there might have been changes in their status, economic status. That is something which I give. But then thereafter there have been no survey, and we are limited to that particular list. So there may be cases of unfair exclusion and unfair inclusion. I'm not denying that. But ultimately, in a country like India, you have to peg your eligibility criteria on certain well-defined systems. Otherwise, anybody can claim that I'm poor and therefore I should be included. And anybody can claim that that person who's included is not any more poor and therefore he should be excluded. So those disputes will continue to arise. But as of now, we have that list of 2011, which actually works as the defining kind of book for us to include or exclude from Ayushman Bharat. So, I'm sorry, I cannot kind of change that situation unless the government takes a view that, and the whole idea is to actually benefit the bottom of the pyramid. So 40% of India's poor population is covered under Ayushman Bharat, and that's the whole idea. And that will continue to happen. And maybe if tomorrow the government changes the criteria of eligibility, then of course we'll go by that criteria. Thank you very much.
Thank you so much, sir, for taking the questions. So I would just like to say pay my heartiest regards to you, and we all are obliged from the behalf of the Public Policy and Opinion Cell to sir, you gave so precious time to the session, and it was really very much required for us to get acquainted with the National Digital Health Mission, because we all are, we see all these things in a newspaper and we see in the news channels, but we don't get the insight of it, that what actually these are. And we just yearn that more and more people get the benefit of it, and it reaches to the basic roots of the, the India, where people are actually want these systems to get, you should actually embrace the system, and India should come with the flourishing strides in each and every sector. And as far as this health sector is concerned, so we know after the predicament time of the COVID-19, we came to know that why this health is so much important, and the interplay of the technology with the health sector is the eminent thing. So it was really, really, sir, such a tremendous session, and I would just like to thank you again, sir. So thank you so much, sir.
Well, Thank you very much for having me on this, and I think it's always a pleasure to interact with my students of faculty of my alma mater. So thank you once again, and thank you, Professor Suvankar, for helping me and inviting me. Okay, bye bye.
Thank you, sir.
Take care.
Thank you, sir.
Have a great day. Okay, bye bye.
With that, we come to the conclusion. We'll be having the next session at 6:30 p.m. and we'll be joined by Pari Bishnoi, who is currently the Assistant Commissioner in Sikkim Gangtok, and we'll be having a session on life as an IAS officer. So all those who are interested may join it. The timings are 6:30 p.m. and you must have got a mail attached with the link. Thank you so much for joining. Nikhil, meet end kar do.